Studio rolling. 5,
Okay, sir.
4, 3. Dear viewers, welcome you all to our show OSA, that is Orthopaedic Solution Academy. Hope you all are well with your friends, family, and your patients. Dear viewers, today our topic is mini Ilizarov technique in hand and fingers. What is mini Ilizarov and how we can apply this mini Ilizarov in case of hand and fingers? That will be discussed today. And the speaker is the one and only, the legendary Ilizarov surgeon from subcontinent, Professor Mofakhkharul Bari, sir. I would like to request Professor Mofakhkharul Bari, sir, to join with us.
Tanvir, good afternoon, everyone.
Good afternoon. Thank you very much, sir. Dear viewers, we have learned academic expert with us. One of them is Professor Omer Barawi, sir. I would like to request Professor Omer Barawi, sir, to join with us.
So much, everyone. Good afternoon.
Good afternoon, sir.
To meet you again. Thank you.
Thank you very much, sir. Dear viewers, we have two learned academic experts. One of them is Professor Novikov, sir, from Kurgan, Russia, and another one is Dr. Shamsul Huda, sir, from Patna, India. Hope they will connect with us in the coming part of our program. Dr. Shamsul Huda, sir, has joined with us. Sir, welcome. Welcome to our show, OSA.
Yeah, thank you. Good afternoon, Dr. Tanvir. Thank you.
Thank you very much, sir, for joining with us. Now, I would like to request our honorable speaker, Professor Mofakhkharul Bari, sir, to start his presentation and share his screen with us. Sir, would you please share your screen with us, sir, please?
Okay, thank you, Tanvir. Dear friends, my dear colleagues, good afternoon. And today I would like to talk on mini Ilizarov in hands and fingers. How we can correct the trauma cases and the deformity cases in hands and fingers by applying the mini Ilizarov apparatus. So these are as usual. So before going to start, yes?
Sir, we cannot see your slides, sir.
You don't see my slide?
No, sir, not yet, sir. Would you please share it again, sir?
Not sharing, not sharing. It's okay now?
We hope so. Yet not. Yes, sir.
Yes?
Yes.
Yes?
It has been shared. Yes, sir. It has been shared.
Yes,
Please
okay.
proceed on, sir.
So, my dear friends, sorry for the interruption. Today I'd like to talk on the mini Ilizarov with hands and fingers. So these are as usual that like to show all these slides. Now you can see, I think so. I think so, you can see. So
Yes,
dear
we can
friends, Professor Ilizarov, when he introduced regarding this mini Ilizarov in case of small bone fractures and deformities, Ilizarov method is a successful orthopedic surgical technique designed to lengthen or straighten bone and soft tissue. Additionally, the innovative device and technique can save limbs that might otherwise be amputated. An Ilizarov external fixator or Ilizarov frame is a ring-like device, but in case of these fingers and the hands bones, we can use the mini Ilizarov fixator. You can see here, mini Ilizarov fixators are useful for treating all varieties of trauma, deformities, lengthening, cosmetic remodeling, contractures, pseudoarthritis, and childhood clubfoot, and not the adult and lengthening of the stumps, etc. You can see here in the right side a picture how we can apply the mini Ilizarov fixator in case of metacarpal bones. So regarding the hands, you all know all these things. And hand is a prehensile, multi-fingered appendage located at the end of the forearm or forelimb of primates. The human hand has 27 bones. The carpals or wrist accounts for 8. The metacarpals or palm contains 5. The remaining 14 are digital bones, fingers, and thumb. The thumb has 5 bones known as metacarpal bones, 1 to each of the 5 digits. These metacarpals have a hand, a shaft, and a base. Look at the right side. You all know all these things. These are the pictures that you can show all the 8 that is carpal bones, metacarpal bones, and proximal phalanx, middle and distal phalanx. So if we think about the indications and contraindications for transosseous osteosis of the hand, we must know all these things: closed and open fractures of the phalanges and metacarpals of the fingers, replantation of the fingers and the wrist, non-united fractures, malunions and pseudoarthrosis, post-traumatic stumps, hyperplasia and congenital anomalies, the bones of the hands for their elongation, congenital syndactyly, and of course the joint contractures. Contraindications to, if you want to go for osteosynthesis, that are related to apparatus and include the widespread pyoderma, angiopathies, and the inappropriate behavior of the patient. This is the contraindication. You cannot go for mini Ilizarov fixator whenever your problems with this pyoderma, angiopathy, and behavior of the patient, if patient does not cooperate with you. So, regarding the osteosynthesis of the fracture of the hand bones with the mini fixator, nowadays traumatologists and orthopedists are able to treat a given pathology using nailing, mini plates, and transosseous osteosynthesis. The chosen method frequently defines the result. Satisfactory results following intermedullary osteosynthesis were reported in 4.6% of the cases compared to the unsatisfactory results in 1.5%. Indications for osteosynthesis using mini fixator, as mentioned above, are closed and open fractures of the metacarpals and phalanges of the fingers. Open and intraarticular fractures with their small bone fragments are also well suited for osteosynthesis, as are cases in which there is damage to the tendons and neurovascular formations of the bottom third of the forearm. At osteosynthesis, the plane of wire insertion in bone fragments should be perpendicular to the longitudinal axis of the bone. Now, why destruction osteogenesis? We must have hypothesis that if you think about the biological activities, progressive regional due to regenerate could increase regional blood supply. And when you are talking about the biomechanical joint leveling and load distribution of, the Kinbox disease or the scaphoid non-union, you can apply this kind of mini Ilizarov fixator. This is a minimally invasive technique. Control lengthening, you can do whatever you like, and no need for bone grafting, no hardware, in place. And method of application can be used unilateral or bilateral, with or without hinge, application on lateral or medial aspect, and avoiding the digital neurovascular bundle, fixator retained for 6 to 8 weeks maximum. Now, before going to apply the mini Ilizarov fixator, you must have clear concept and clear idea regarding the different parts of the apparatus of the mini Ilizarov fixator. For the osteosynthesis of the sharp tubular bones, mini fixator can be individually installed on a dorsum of the finger or a metacarpal. Each device contains 2 units for wire fixation. Here you can see the different parts of the mini fixator. These, if you compare with the original Ilizarov fixator, these are their small sizes, and these plates are smaller than the normal plates that we use in case of leg, hands, in case of forearms, arms, and thigh bone or the femur. So, dear friends, you can see here scheme of the introducing of wires in the bone of the hand and their fastening in the fixation unit of the apparatus. If you think about this diagram, look at these tendons and nerves, and this is the vessel. This is the cross section of the bone. How you put your wires like this, then you go for 45-degree angle. This is the veins, and these are the tendons, and this is the wire fixation nuts. And this transosseous osteosynthesis, the treatment of post-traumatic stamp of the hand, you can see here how you can put the wires, how you can apply the wires. Look at the A here, look at the B, the fixation, and you fix the mini fixator here, and this is the final view of the fixation after fixing the mini Ilizarov. And this one you can see red marking. You're going for lengthening by putting the mini fixator. This one and this one, how you can put. So one wire from this direction, another wire from this direction. Sometimes you can put the 3 wires also. You can see here 1, 2, and 3. So this is the diagram, and this is the diagram. I'll show you practically how to do that, how you can lengthen for and deformity correction by this mini Ilizarov fixator. This is, you can see, this is the one of the variant of mini Ilizarov fixator, mounting for lengthening the middle phalanx. If you want to do that in a congenital anomaly, this is not so hard, very simple, but you must have meticulous, intelligent follow-up. Then you can do a very good amount of lengthening with good callus formation. These are the pictures that you can show whenever you are getting this kind of metacarpal balls. This is the true effects of the deformity. You put your fixator like that and then go for a simple osteotomy, and you can go for lengthening. This is the callus formation. So, dear friends, you can see here apparatus for lengthening of the stumps here. How you can do that? Again, you can pull the wires like that, go for a bending, fix it with mini fixator. These rods are smaller than normal rods with the Ilizarov rings. So see how we have fixed the bone and bending it. Whenever you are going for 45-degree angle of the bending, you will get the force here. And this is the distraction rod. You can go for lengthening here. And this is how you can put the apparatus. So look at this. This is the for lengthening of the 4 bones. These are the lengthening of the 4 metacarpal bones. How you can go for lengthening. This is a bow. You can put a small bow here, then with hinges and mini fixator here. Do a corticotomy here, and you can go for lengthening of the metacarpal bones. And this is for the one-time lengthening for the 2. This is the 2 bones. At the same time, you could go for lengthening. So now this is for the lengthening of the congenital stumps shortening. Congenital apparatus for congenital wrist and stump lengthening, and this is for the lengthening of the digital phalanges. And these are the pictures that during my training period, postdoctoral, I took all this and I learned from all this how to go for lengthening of the, this you can see here, the embedded all the phalanges. You can go for lengthening like this. Put this with mini fixator. This is 1.5 olive, and then fixed to the rods and bars. Do the osteotomy, and you can go for lengthening. So these are the varieties of application you can see. Before doing any kind of surgery in the hand, lengthening, you must have clear concept regarding all these types of varieties of application of the bones of the mini fixator. Mini fixator. You can see here again, very simple, only you must be meticulous. Then, what are the advantages of X-fix in hand injuries? Simple to apply, that I told you, cost effective, useful in compound injuries, comminuted fractures. Removal does not require anesthesia. Interphalangeal joints can be braced. MP application is associated with destruction angiogenesis. The problems of mini Ilizarov fixator, as usual, this can be cured, pin track infection, and you will get the pin loosening when your bones are too much osteoporotic. These are very simple complications. You can overcome them during your treatment. Now, I would like to share my experiences with the fixator of the mini Ilizarov, how we can do that. See, dear friends, you think this is a very simple case. Look at the bending of the fifth metatarsal bone of a principal of a college. He came to me and then fixed it. We have fixed it. See, we have corrected the angulation by putting the mini Ilizarov fixator in his left metacarpal bone. See, and then this is beautifully corrected. You can ask, I can put it by simple plaster. Yes, you can do that, but by doing this mini fixator, you can very nicely correct the angulation, and you don't need to do any kind of immobilization. Patient can hold this mini fixator very nicely in his hand. So now, this is the machinery injury. You can see here of the right hand with auto-amputated thumb and hanging metacarpals. So these are the very simple with mini fixator here. For lengthening, I have done the thumb, and then this is the mini fixator. This is the, now patient can write with his hand. You can see this is the lengthening of the metacarpal bone. So this is the, after 8 months follow-up from this situation to that situation. So page number 3, you can see here, severe machinery crash injury of the hand. This is too much disorganized of a 17 years old boy. See, look at this. You cannot even identify what are the problems in the hand. Look at this, AP and lateral view. Then gradually I have treated. This is the post-operative stem at the level of the left proximal thumb phalanx in a 17 years old boy, was osteotomized. Destruction started on the 5th post-operative day, continued for 35 days for lengthening. 2.5 centimeter was done. 2.5 centimeter lengthening of the thumb is visible. You can see here, 2.5. Thumb plays a very important role in gripping the hand. Any other things? And this is destruction technique. Osteosynthesis is the treatment of acquired and congenital shortening of the hand bones using mini fixator. This was published in October 2016 in American Medical Journal. So look at these, dear friends. So this is machinery injury of the right hand, deep multiple laceration with multiple hand tendon injuries. This is exposed everything. So look at this. The damage cage came to my place. Initially, I put this with this one bow and one ring here, and then gradually what happened, you can see here during the treatment. These are the exposed bones, and then look at this. What happened then, and gradually while you were started doing treatment, you can see here. We have sequentially we applied from one ring to another ring, that is the mini fixator, and this is the fixation of the mini Ilizarov by putting the mini Ilizarov fixator in the hand. This is my two fellows, one from India, Vijay Bada, doctor, he is a knee and hip prosthesis surgeon, came to my place for doing Ilizarov surgery. Now he's doing a lot of Ilizarov cases in India. And this is from Malaysia, my fellow. And look at this, from that situation, very bad case. And then we have done what we have done. Now this gentle boy is working in Saudi Arabia, and he comes to my place every year just to show his hand. Now you can see this is a macrodactyly of the left middle finger. Look at this macrodactyly of left middle finger, left one, and right one, just compare. This is macrodactyly. Radiogram, left finger, before surgery. Now you can see here what we have done. We have, this is the close-up view, a bow, a small bow with mini Ilizarov fixator. And then, now look at this, from that situation to this situation. This is the third bone before treatment, macrodactyly, after removal of the soft tissue debulking and the shortening of the third proximal phalanx of the middle finger. And this is the case, 18 years old boy. Look at this, right hand and the left hand. This is post-traumatic shortening of the proximal phalanx of the right middle finger. Radiograph of the right hand, shortening of the proximal. This you can see, this is the right, this is the left. Left hand is okay, this is the short hand. Now you can see here, compare this one and this one. And then what I have done, see, with mini fixator, just you apply this and do the corticotomy, go for lengthening. You can see the good callus is going on. Radiographic view of the osteotomized and the lengthening part of the proximal phalanx with ongoing callus formation. And this is the external view. And then finally you can see the view of the patient after treatment. Look at this and look at this. This is the right hand and this is the left hand. So before surgery, you can see here, and this is after treatment, you can see here. So these are the cases that you can usually go for mini Ilizarov fixator. This is again a machinery injury with gangrene middle or ring finger of the right hand. 16 years old boy. Look at this, came to my place, and then I have treated with mini Ilizarov fixator during the treatment. Look at the just close view of that. This is during treatment with mini Ilizarov apparatus. And then what happened then? Then this is the situation. This is the final view of the patient. And another case you can see here. You can go for, of course, the mini plate and screws. But this kind of fractures with angulation, you can correct nicely. See, look at this. You have corrected the angulation. Put the mini Ilizarov fixator by putting the two weights and bending them 45 degrees. This is after second day of the application. And this is Ilizarov in situ. You can see. And the patient can ride with the help of the mini Ilizarov fixator. Now, look at this. The smiling patient with the mini Ilizarov fixator. This is the radiographic view after 1 month. And this is the fixator. Patient can ride easily. So this is the final view. You can see after 2 months, after dismounting the mini Ilizarov fixator, before and after. This is the after. So again, you can see, dear friend, 50 years old boy with flexion contracture of the right distal IP joint. This is a very, critical case. You can see here, distal, and He was treated elsewhere. Then what I have done, see, a small olive with the wires. I fixed this, gradually distracted that one to correct the uniformity, and this is the final view. You can see how this is corrected from that situation to this situation. This almost corrected but united also. So, and finally you can see neglected open injury gastrulio 1. Look at this. Swollen, local temperature was too much high. This is open, and then these are the cases that you can easily put in the. I have put the one half bow and then fixed to the melee fixator. See, then easily you can correct after 3 months follow-up from that situation to this situation. So these are the cases that you can go for mini Ilizarov fixator. Dear friends, I would like to show you one scaphoid non-union. Look at this. By mini Ilizarov fixator, combination of Ilizarov fixator. See what I have done. There are two ways to correct this. You can pull the two olives from the two directions by putting and give the compression by putting the olive wires. You don't need to open that, and by doing that you can correct easily. You can get the union of the scaphoid non-union. Now from this situation, this is the scaphoid non-union. From that you can see this is united only after 5 months. So another machinery injury. These are the cases that you can fantastically manage by this mini Ilizarov fixator. Look at this, the middle one. This is the injury, and this is the, he came late to my place, and then we have fixed the mini Ilizarov fixator again, mini Ilizarov fixator, and then this is the lengthening, a little bit angulation, but this is the callus formation, and from that situation to this situation, middle one. Okay, so when you are applying the mini Ilizarov fixator, patient can easily mobilize. See, we easily mobilize the mini Ilizarov fixator in the hand. So this is the beauty of mini Ilizarov fixator in the fingers and in the hands. So be master of one, you will be a good expert. You can provide quality service. You'll get the happiness, less complications, and less mental stress. Thank you so much for your kind attention. So mini Ilizarov frame in hand offers an effective modality of treating articular, comminuted, compound multidigital trauma, and also protects the repair tendons that I showed you. And this is, I've always, whatever I have shown you, that is on my evidence, science, and of course the surgical skill of the patient. Ilizarov surgeon can show all these kind of difficult cases by putting the Ilizarov fixator in the hand and in the fingers. Thank you so much again for your kind attention. Thank you very much.
Thank you very much, sir. That was a brilliant presentation, and we all think that the mini Ilizarov is highly effective to manage the difficult cases in case of hands and fingers, and we can also make lengthening of the fingers that you never expect without Ilizarov. And now I will go to the academic expert panel. And now first, I would like to request Professor Omer Barawi sir to share his knowledge regarding the presentation. Professor Omer Barawi.
Okay, yes, please. Thank you so much. Really very nice presentation. I have two questions. One of them, how many millimeters daily can be elongated? Is it 1 or half in the fingers? The second thing, regarding non-union scaffold, how many days you are going to do distraction, then compression, or you are doing just compression? Thank you so much.
Yes. Two good questions. If you go for proximal phalanx, lengthening, you can go for 0.50 or 0.75, not 1 millimeter per day. Less than
Yes.
that.
Yes.
You can do that. Yes. This is
Yes.
number one. Number two questions regarding the non-union, you can go for two methods, by compression or you can go by distraction. You can go for compression, very 10 days, 10 to 12 days for compression. If you go for distraction for 2 weeks, these are the two methods, whatever you like. So I applied my cases. I have shown you the cases of compression, but at the same time, you can go for distraction also. Both the cases in both the in the non-union of the scaphoid bones. Even I have not shown you the lunate bone Kienbock's disease. You can go for lengthening of the ulna for Kienbock's disease. That is osteopathy of the lunate
Yes.
bone. Lunate bone.
Osteochondritis. Thank you so much.
Osteochondritis.
Thank you.
Yes.
Yes.
Thank you very much, sir. Now, I would like to request Dr. Shamsul Huda, sir, to say something regarding the presentation. Dr. Shamsul Huda, sir, would you please?
Thanks, Bari sir, for a wonderful lecture again and so much of learning. I have just two questions here, sir. In cases of the syndactyly, sir, we are applying, I can see just a single frame. I thought it would be two frames on both the fingers to just distract gradually, sir. Give more elaboration regarding the syndactyly, sir.
Yes, in case of syndactyly, you just put the olive from two directions and you go for distraction gradually. You can put one bow here and one rods or two rods, two sides from the two fingers, and go for distraction by putting the olive from the two sides, this direction and that direction, and go for distraction. When you are getting enough amount of skin, then you can cut easily. I have not shown here the syndactyly or polydactyly. I could show you, but I could not manage due to my time constraint. Okay.
Yes, sir. Maybe we can have that in special. Is the cases of contracture, sir. So would you put a hinge here to just extend the finger, and plus, do we need some plastic surgery also?
I could not follow your duty interruption of the. You again tell the voice is not clear.
In finger contracture cases because of burns, sir. Flexor contracture cases.
Yes.
So do you put the hinges over here to extend?
Yes. When you don't mismatch the hinge. This is your contracture of the joint. You just put one mini fixated here, one here, and put your hinges from two sides or from the top or from the below, from two sides. You must put the hinge in the true apex of the deformity. Then you can gradually distract. If you put the hinge not at the true apex of the deformity, you may invite a dislocation of the joint. So that's why it is very important to put the hinge in your center of rotation of the joint. That is in the center of this finger, the proximal IP joint or distal IP joint.
That is very important. Plus, sir, do we need some extra plastic surgery also for the soft tissue contracture?
Sometimes
we need some plastic surgery also for the soft.
No, you don't need gradually. You don't need to go for any help from the plastic surgeons. You don't need the cases. You can release minimally. You can do the combination of a little bit soft tissue release joint and then combination of mini Ilizarov fixator. Both soft tissue release. As for example, if you go for the waving of the pterygium or waving of the elbow of the hand, you need to go for the release of the soft tissues and tendon lengthening. Then you apply the Ilizarov fixator. That means you can overcome the time by doing these two. If you don't release, you put the Ilizarov. In case of arthrogryposis cases, bones are not too strong, then you can invite any kind of fracture, this and that type. So that's why you need to go for soft tissue release and combination of Ilizarov. And good amount of range of movement you can get. Follow me, okay?
Yes, sir. Yes, sir. That was an excellent discussion. I think Dr. Shamsul Huda sir can hear all the discussions. I would like to thank our honorable speaker and our academic expert for being with us, and definitely Raj TV and Maria Sinti Specialized Hospital for sponsoring our program. I hope we will connect in the coming Friday with another magical topic. Till then, I'm Dr. Tanvir Ashraf saying bye-bye to all of you. Bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.